My name is Victoria Dehart, and this is my Clinical Quality Outcomes Project presentation of findings. To introduce myself for this case, I'm a clinical nutrition manager of a 400-bed acute care facility. To introduce the topic at hand, the topic resulted from me being approached by a senior administrator um, to think of ideas for an improved community outreach. Um, and as a local technological company was hosting a competition for $200,000 grants to improve the health and well-being of the community. This is where the community outreach started. So after I had a meeting with my clinical staff, we submitted a grant to support the idea of a diabetes education clinic to try and earn that grant money. And this would be on the campus of the acute care facility, and it would be staffed with 20 hours a week by a registered dietitian, CDE, and then 10 hours a week by an endocrinology resident. And so we did receive the grant for um, the diabetes education clinic. So, in receiving that grant, we had to establish billing and coding capacity for the clinic. So we wanted to design a research study that will evaluate the relationship between diabetes education sessions and health outcomes, which include um, A1C levels, BMI, blood control. So we want to prove that attending diabetes counseling sessions with a registered dietitian will reduce admissions of uncontrolled diabetes to the hospital, that it will reduce A1C levels, reduce BMI, and then control patients' blood pressure. Um, and then to use data to justify these things or to prove these things, um, we want this data to show continued funding of the clinic, to show continued participation from the community, and then to be able to show data enough to show the need for the education to be able to staff the clinic with a full-time registered dietitian and CDE. So this is what the literature says about the background of diabetes involving nutrition education and um, its relation to um, diabetes health and lab values. Um, so type 2 diabetes is the most common form of diabetes, and it affects 90% of the diabetes population. And this typically occurs after the age of 40, which this research is what went into establishing the population age of the research. And then diabetes self-care management education, known as DSME. This includes education on meal planning, changes in lifestyle, physical activity, and many other habits. The incidence and prevalence of this disease is growing, and so this shows that the need of dietary education is becoming increasingly important. So DSME showed an increase in knowledge and adherence to diet therapy, physical activity, glucose monitoring, wound care, glycemic control, body weight, BMI control, and decreased risk of um, microvascular complications, cardiovascular disease, and then hemoglobin A1C levels. So these show the reasons why we are checking those lab values that we are checking for this research study. It's also shown that poor compliance of education is linked to poor disease prognosis and increased risk for developing comorbidities and complications, and a higher mortality ratio, which this could go into the research of the hospital readmission rates. And then with diabetes education, patients are hopefully equipped with the knowledge, skill, and confidence to accept the responsibility that they need to take care of themselves, including collaborating with their healthcare team, making informed decisions, solving problems, and developing personal goals and action plans, and coping with emotions and life stresses. So not only does this diabetes education include education on nutrition itself, but it also includes how to deal with diabetes as a disease. And these are my resources for the literature. So the methodology of the research project is the population sample, going back to the research, includes patients 40 and over with a new diagnosis of type 2 diabetes, and that they would have no history of having diabetes, education on management. And so this population was narrowed down to 126 participants. So for the data collection, individual counseling sessions within a 4-month time period, each participants were allowed up to 3 sessions. So the session numbers ranged from 1 to 3 attended sessions. Descriptive statistics were used in the ways of categorical and continuous data. Categorical data was used for sex, A1C, BMI, and then blood pressure control, meaning a yes or no if their blood pressure was controlled. Continuous data was used for age and then their diagnosis of diabetes. Inferential statistics was used to discover the mean difference in A1C before and after the study, and then BMI before and after the study based on the number of education sessions that the participants attended. ANOVA was used to do the mean difference in emissions based on the number of sessions that the participants attended. And then chi-square analysis was used for blood pressure control difference, again, based on the number of sessions the participants attended. So you can see how all of the data is used to discover the difference in before and after the participants attended education. So to the results, this chart shows that the blue is the A1C before education, and then the orange is the A1C after education. So this shows that the A1C related to the number of sessions attended. And you can see that the starting A1C, those blue lines are trending higher than the A1C after the sessions were attended. This shows the BMI related to the number of sessions attended. So you can see that these are more closely aligned than the A1C, but still you have that orange going a little bit lower because you can see the blue is a little higher than the orange sometimes. These results show the ANOVA test between showing the mean difference in admissions and number of sessions. So if you look at the p-value, the p-value is not significant because it is higher than 0.05, showing that there's not a significant association between the number of times that the participants went to an education session and the number of times that they were admitted from uncontrolled diabetes. However, the F value is significant. It is, you can see it's 0.02, so it's less than 0.05. These two charts show the BMI control related to the number of sessions. So the chart on the left shows that the orange is if they have controlled blood pressure, and then the blue is if they have uncontrolled blood pressure. So you can see that starting out, you can see the difference in blood pressures there. And then after, you can see that the 0 is for if they have their blood pressure controlled, and the 1 is if they do not. So you can see that they're flip-flopped, but you can see that the number of them who have it controlled after education sessions grew quite a bit. So other important results are the mean age of the participants, which is about 60 years old. This would be a standard deviation of 11.32. And then that there was no significance found between the mean difference of A1C levels and BMI according to the number of visits. So the main conclusion is that there is no correlation between the intervention of education in a 6-month period up to 3 sessions. So education in this case had no relation to um, lab values or overall the study that was done at hand. The number of participants with their blood pressure controlled, however, did increase after the education sessions. Um, and then more RD sessions that participants attended, the lower their readmission rates were. However, the study did fail to display that lower A1C and BMI levels were associated with diabetes education. My recommendations for the study would be to improve the RD education session participation. I feel like there was no, um, besides the $50 that were paid to participants, I feel like there was no push. We don't know if there was a push for participants to attend as much sessions as they could possible. And going hand in hand with that, follow-ups. I feel like the importance to push participants after they've came to one to follow up is super important. And then to increase the amount of sessions offered, I feel like there could be a lot more material covered within more session numbers than just three amount of sessions. And then to include material of education, so we don't really know what the material being taught was. And there's so much research on the importance of teaching label reading, carbohydrate counting, physical activity, those things. So even if you had a session on, if you had 6 sessions and you had them on um, overall diabetes, the pharmaceutical side of diabetes, nutrition side of diabetes, physical activity, wellness with diabetes, and then, just basic stuff like carb counting and label reading. I think that could really help. And this is the end of my presentation.